Let me close my door here in 1 second. Well, good morning, everyone. I hope everyone's having an okay day today. I know you guys are starting early. It's a little dreary here in Athens. There is one of the things that I will put up or have some slides up is actually objectives for this particular for this weekend, which I forgot to put on the beginning of the slides here. So we'll put those there. And the way we work this is like the way that I've taught you guys before, is that we will take a break about every hour. We're going to move through the anti-anxiety drugs and the anxiolytics, and then the other thing, which some of the sleep medications. And then there's been some new information that's recently come out. It's not really new information, but it has been information that basically has been reemphasized. We'll be doing is that there will be like a two or three this at the end of this morning session. With regard to it, I will this will be part of the poll as far as attendance and so forth. We'll do that right before lunch. Typically what I'm going to do is to give that to you just a few minutes before lunch, and then we over the answers of the 3 or 4 question quiz at the end of the day. I know there's been a lot of discussion with regard to schedule, and you should have gotten an email from to log on or join the meeting tomorrow at about 5. We'll verify the time and everything and let you guys know, but it'll be a few minutes before the lunch break is over, and to have some discussions. And I know there's some emails that have been responding to the scheduling and so forth, so she will address issues. Keep in mind that from a standpoint that we will try to have the quiz available. You know, the test for this material should be up by Tuesday. As before, if you guys have questions, do not hesitate to contact me by emailing me, and I will try to get back with you as soon as possible. And so I will do everything.
Our sound is cutting
out. So let's see if that's, let me change my mic a little bit, see if this goes a little bit better. And we'll to we have some sound issues, let me know, and I'll try to reposition the mic or whatever. So this weekend we're going to cover anti-anxiety drugs, and this is that has we see a lot of people on. Many of you have patients that are on these medications. One of the things we see is sometimes these people are taking them on a daily basis. Sometimes these are occurring PRN, and personally, sometimes the PRN situation is what I've seen more patients have a little bit more difficulty with sometimes, because they go for a while and then get stressed and they take medication, and we may get side effects, and that whereas if they're taking it every day, they may have developed some tolerance. But from that standpoint is we'll address some of those issues. And of course, one of the things that we see is that a lot of individuals are using benzodiazepines, and I'm sure most of you have heard all of the media with regard to the opioid epidemic. But one of the things that came out just a few months ago is someone made a comment that you do have an opioid, there's a benzodiazepine epidemic. And the problem is we are running into issues with people and misusing some benzodiazepines. Things I want you guys to be is with the benzodiazepines that these are the drugs that I think you're going to out for patients. may try to manipulate to get those. And so just put that on your screen, in the back of your mind with regard to these benzodiazepines. So when we're looking at anxiety disorders, we're going to talk about, first we'll start off with a discussion of the pathophysiology, which involves a large portion of the nervous system. But with anxiety disorders, we have generally the generalized anxiety disorder, GAD. We see phobias. We see panic disorder. We also have post-traumatic stress syndrome, and there's been some a couple of new drugs that are being looked at for PTSD. Just had a student that did a seminar, and I will probably provide you with a couple of the papers that she had dealing with the use of prazosin for the treatment of PTSD, and also the use of potentially ketamine. We also include obsessive compulsive disorder in this group of drugs also, in this group of disorders also. So when you see the prevalence, and again, let me just remind you that for your studying purposes, the slide should be highlighted in red, but there are a few, I think there's 4 or 5 of the initial slides that are not highlighted in red because it's just general information. Some of these prevalences and incidences can change depending on when they were collected, but we do see it is a pretty prevalent disorder in the United States. I would say that sometimes it is not necessarily properly diagnosed. We see that an estimated incidence of 18% in a lifetime prevalence.
We're still having issues with
Women
sound.
tend to be affected more than men, and we're having more issues with sound. Okay, let's see if this will.
I kind of doubt adjusting a microphone is going to do it.
All right, let's see that potentially more effective than men, but we also understand sometimes males may not be diagnosed or go in to be diagnosed as frequently, some people would say. But we do see that there is, people suggest that maybe 1 in 3 people may be at risk for developing some sort of an anxiety disorder sometime in their lifetime. One of the big issues that we look at with these anxiety disorders is going to be how much it affects their normal everyday life. The other issue that comes into play is that the treatment of these anxiety disorders, we see, I know on our campus, we do see that individuals do not want to come in for counseling, but they would much rather just be given a pill. And so we do see that sometimes, and especially going to general practitioners, what we also see is many times that the individual just wants to go in, and the question of whether the general practitioner actually has the time to sit down and make a diagnosis and do the complete diagnosis is a question that comes up. One of the issues that has been, it's been around for a long time, but it affects all disorders, especially psychiatric disorders, has been with general practitioners prescribing. The aspect of it is that there's the discussion of how long a practitioner has for each patient. And in order to stay solvent and make money, practitioners have to see X number of patients, which means that many times the patients may do not get a thorough examination, but really just more of a, here's what's bothering you, and here's how we can fix it real quick. So to follow up on that statement, one of the things that you may see is a patient may be coming in with regard to multiple medications. And one of the things that, in talking to psychologists that are dealing with this in the circles that I travel around in, a lot of times what they're doing is sometimes maybe actually removing some medications The other thing that we've seen is sometimes certain other medications may be contributing to the anxiety. For example, stimulants that may be co-prescribed. We may see that supplements may actually be contributing to that. And so there's another issue about sometimes with regard to with CBD, which is very much in the news, and I'm getting a lot of questions about is some of these products with CBD are actually creating issues. And when we talk about sleep medications, I can talk to you a little bit about some side effects, which, for example, just simply changing a generic may create some problems that may lead to anxiety. So there's a lot of issues that come into this very commonly recognized disorder. The significant cost in the U.S. Most of the cost, in fact, it's estimated that 50% of those costs are actually towards non-psychiatric medical treatment costs, other things that may come into play, loss of work and things like that. Interestingly, just a little over a third of patients with anxiety disorders, only about a third, roughly a little over a third, actually use any form of health services. Visits with psychiatrists, about 13%, other mental health practitioners, 16%. And of course, as you would anticipate, the majority is probably going to see general practitioners. The other thing you see with all these anxiety disorders is we see a lot of people searching on the internet, looking for options there, and we see a lot of, let's say, peer assessment, if you will, that the peers they're going to their peers for what are you taking when you get stressed. Definitely see that in the patient population around campus here. It's one of the things we sort of preach about is the fact is people borrowing medications. We see a lot of this, especially associated with things like test anxiety and things like that. So when you look at these first few slides, is really, you guys, I think, have a good appreciation for basically how anxiety shows up and the type of things that you see. We will probably do a couple of cases. Either you may have one tonight, we may do one or two tomorrow with regard to seeing how you address this. We see a lot of people using different modalities and different medications to address it. Sometimes the background, we probably see more physicians, particularly general practitioners, prescribing benzodiazepines, whereas we see other practitioners maybe moving towards using some of the SSRIs and other meds. So one of the things, though, that you need to be aware of is that patients with anxiety disorders really have high comorbidities with other disorders. I think most of you appreciate that fact. We see it's not uncommon that these individuals may suffer from depression, that they may have other personality disorders. One big concern is substance abuse disorders. We do see a lot where that people are self-medicating the anxiety disorders by using drugs, and many times prescription drugs may fall into this category. And we also may see learning disorders. And sometimes these comorbidities are actually contributing to the anxiety disorders. The other thing that we see sometimes is that many times that individuals come in, the anxiety disorder may be treated more so or up front because people thinks it may be easier, and that may be the thing that the patient is most concerned with. We see a lot of students that get test anxiety and these type of things, and of course they want medications. They're taking stimulants like ADHD drugs to help them with their studies. We see a lot of abuse of that on college campuses and in younger people. We also see it in young professionals, white-collar workers. We see a lot of abuse of stimulants, and the stimulants can contribute significantly to the anxiety disorder. We see people that get very anxious over perceptions of what they think they should be and so forth. And so one of the things is that, again, trying to find what the actual root of the anxiety is going to be very important, but also the recognition that your choice of drug when you are treating these patients may have to consider the issue of, for example, is it going to create any other problems? Is it going to, for example, contribute to substance abuse? For example, with benzodiazepines, that is a big concern. So that is one of the big things that we have to be careful with these particular medications is, for example, using some of the SSRIs, if they're depressed and sometimes if they take too much, they may self-medicate by trying to increase dosage. So these things in place, so we have to be aware of sometimes whether some of the presentations they give us are side effects of some of these drugs. Sometimes are these presentation side effects of them discontinuing one of the other drugs, and that sort of things. That, for example, many times people may get, dependent on benzodiazepines, and the anxiety increases when they start coming off of it, which may promote them to use higher doses or combination of these meds. You guys have to bear with me just a little bit. I'm having to, I keep looking for the buttons on this because I use a different program when I'm teaching at UGA here, and so the buttons are slightly different. But this slide here is really one of the things that I just went into is the anxiety secondary to some other factor? And one of the first things you want to think about is it possible that the anxiety is secondary to substance abuse? Could they be going through withdrawal? Would be an issue. Some of the signs and symptoms of these anxiety disorders may very well be symptoms of severe psychiatric disorders or psychosis, for example, or mood disorders. But the other thing is that you have to consider is when somebody comes in, we have to be very, very careful about being tunnel visioned from a standpoint of basically, is it going to be a situation where that is the anxiety potentially associated with something like hyperthyroidism? So some of the symptoms of hyperthyroidism, the exophthalmia, the bulging eyes, but you might want to check to see if this is it could be due to an elevated thyroid, which tends to make people more restless and show signs and symptoms that we see. It's similar to anxiety disorder. As I mentioned before, are they potentially withdrawing from some other medication? Sometimes other medications can produce, for example, if they're taking benzodiazepines, that can, not benzodiazepines, antihistamines, that can produce some restlessness and things like that. So these are issues that basically have to be considered and ruled out. And sometimes it may require some additional testing. Sometimes dietary things where they're having hyper or hypoglycemia can produce some symptoms very similar to anxiety disorder. So again, this slide here is it's sort of an older slide, but gives some lifetime prevalences of various different types of phobias and subtypes of anxiety disorders. So these are just one of the things that, just gives you an idea. We do see, specific phobias tend to be a little bit higher in certain, in females more than males. We see panic disorder tends to be more in females, but even agoraphobia. One of the things I think you guys know is I do martial arts, and one of the things that we do see is we do see a lot of women coming in with a lot of fears and things like that sometimes has been part of an anxiety disorder that is that comes in. And myself, and there's another person that is a psychologist, is one of the things that we do see sometimes is that we do have discussions with individuals sometimes about thinking about talking to some people and getting some additional some help there. So one of the things when you talk about anxiety, we see, in fact, I've just had this with some freshmen that I have come in, is they're very anxious over a lot of things. And when I just started talking to them about mental health and things like that, their first thing is they're telling me that their friends, they've been very anxious when they, left their home, as they've been, just came away. This is their first time at college, their first few months. They're anxious about a lot of things. And one of the things we talk to them about is we discuss with them literally the situation of, look, anxiety is one of the things that is a normal that people are going to experience. Okay, it's really, if we look at it, it's sort of a general state of apprehension or foreboding. It involves the autonomic nervous system. It's your body going on alert, if you will, and pretty much getting ready for fight or flight. Now, the thing that is sometimes hard for them to remember is that this can be a positive, this anxiety can be positive and may actually improve performance. And I give them my own experience, which is when I've gone into scenarios when I was a student, or even, legal cases or everything, when I've gone in completely relaxed and so forth like that, is sometimes I've done poorly. Whereas if I'm a little, apprehensive before going in, it's really, I'm a little more on alert, and that's my body basically, getting ready for things. But again, some anxiety actually can be a positive thing. If we look at the next slide here, what we see here is that if you look at the level of anxiety, if we take when you're asleep and considering that you're asleep, typically your anxiety is very low. Your performance when you sleep, you're doing well at sleep, but as far as being able to do anything else, obviously your performance is going to be poor. And then as we wake up and we see an increasing alertness, what we see is that our performance actually will improve. And we do have a point where we have optimal performance. But the problem is basically what happens when we go to the next step. Working with some of the coaches, one of the coaches, I was doing a substance abuse education program for all the teams here at Georgia about 5 years ago. And one of the coaches said, we have the elite athletes in our programs. And these elite athletes, we have them on the edge. Basically, we have them where that they are just basically, the way he was describing it, we have their level of performance optimized for their level of anxiety or their level of stress. But he made the statement is, being that, it means there's very little error. It doesn't take much to push them over where they start losing performance, going, basically their performance starts dropping. So what we see is that we do get a point, everybody reaches this, where that the once you get past this optimum, your performance starts falling off. You become too nervous to get this, and even to the stage where you guys have seen patients like this, where that they become so anxious that they can't cope. So what we want to do is can you guys see my pointer, by the way, if I'm moving it on here?
Yep, we can.
Okay, good. Thank you. So what we want to do is we really, when we're treating somebody with this, we really don't want to get where we're past their optimal level there. Okay. We also want to, definitely want to treat people that's on this downward slope where that we can move them where that they can cope. But, one of the things is that some people think I want all of the anxiety removed. And to do that, we pretty much have to sedate them. And then when the drug wears off, the anxiety comes back. But one of the things that we do find is, and I think you guys see this too, is that the temptation is to just medicate and really not address the anxiety. And even with our athletes, we have people that are talking to them about addressing the anxiety. Of course, with our athletes, we have to be very careful. We can't medicate them because then we got the NCAA issue. Of drug abuse that we have to worry about, or drug use. So if we look at before the curve, so going back to this previous slide, this portion here, before this conserve, we actually look at this as adaptive, and it improves performance. And this is an interesting thing. I was I gave a talk yesterday at a conference in Atlanta. The name of the conference is Zubiquity. I don't know if any of you have heard of these Zubiquity conferences, but it's actually trying to get medicine and veterinary medicine to talk about common things we can learn from animals, and things that we, veterinarians can learn from us. And, many times we're using things in human medicine. But one of the speakers that right before I talked was talking about looking at disease states in general and looking at causation. And one of the things was how certain animals adapt, and that this becomes physiological, and that we could sometimes use these to learn about this adaptive process where it is good. The example they used was a giraffe, and I never thought of it this way, but she was showing that giraffes, they have an enlarged heart, basically a hypertrophied heart, which is what we see in patients with severe cardiovascular disease. And she was showing this was something that hypertrophied heart we would think of as negative, but in the giraffe, basically that enlarged heart is physiological and actually helps them function, because they have to pump blood from the heart up that long neck. So one of the things that they are, people are starting to look at with the great apes and some of these other species, is that how these species have different characteristics that are adaptive, that are physiological, and how this comes into play. So I think there's going to be more research that's going to be emerging on that adaptive processes, how they can be beneficial, and how we can sometimes either take advantage of those or address them when they become detrimental. But I definitely, for example, if we take somebody that works well under pressure, one of the things that happens is that that's an adaptive process. The pressure is one of the things that helps them. If we remove that that degree of anxiety, we actually decrease their performance. And you think about it, if we took somebody that's a little anxious and we give them a benzodiazepine, for example, Valium, alprazolam, to calm them down a little bit, is their performance may decrease. And if we use too high of dose, then they become sluggish and their performance may even go worse. But the real thing we're going to focus on, or what we want to focus on, is really this thing, is when we're dealing with the maladaptive component here, we want to try to treat these patients so that we can get this back to the adaptive stage, not the maladaptive stage. And again, the idea is that when they're in the maladaptive stage, that their quality of life, their ability to function, is decreased. They may still be able to function, but maybe not at the peak level, and maybe it would keep them from, basically enjoying life, keeping their job, and so forth. So what we want to try to do is not to completely remove the anxiety, but we need to basically find a level where that we can move it back to this ascension on the curve, and get them out of the descension. Sometimes, and many times, you can think about, we could do this primarily with, just individuals that are with just basic counseling. But again, the thing about it is our society wants to medicate because it seems to be quicker. I don't have to commit to coming in for an appointment. I'm just out of curiosity of how many of you, when you're treating anxiety levels, you tend to get the patients that want to be more counseling. But do you find that it's getting harder to get patients to be counseled for anxiety disorders because they just want to go straight into the medication? Or do you find that patients are receptive to it in general? what we've seen here is basically we have seen that students are, and some of our staff are more likely to um, basically do the first few things to get them out of their crisis mode. But when it comes down to, from a standpoint of long term, we have harder time. So typically, the first couple of weeks, we may see that they are doing okay and are willing to basically come into counseling. But after that first couple of weeks, we see it dropping off. We start seeing other things start to come into the into problems, or having, I shouldn't say problems. We start having individuals that start having issues that interfere with their ability to come in. So let's look at from a standpoint of anxiety. I think most of you have a good understanding of this, or at least a general understanding with it, but let's go through a couple of things here. So one of the things that happens is anxiety is on this adaptive process. Anxiety is usually linked to the normal fear response, okay? When we get afraid of things, basically our anxiety goes up. So it's a protective mechanism. I mean, fear can be a protective mechanism. At this time of the year, my wife and I we've had more snakes that have showed up in our backyard than we've had in the 20-something years we've lived here. Part of that is because they've cleared a lot that sort of catty corner to us, and we think the snakes have been migrating. And we have a very we have a lot of plants in our backyard. That's one of the things that we do. So the idea was, the other night I was out there and I was working, and I looked down, and about 2 or 3 feet away from me there was a snake. Okay, all right. So my first thing was, there was an immediate alarm reaction, and I used to collect snakes. So from a standpoint of snakes, being afraid of snakes, I'm not afraid of snakes. But on the other hand, when I looked down, I was startled. And immediate. So my first thing was, I had an immediate alarm reaction. I looked down. Here's a snake. I recognized it as a snake, and my first response was to step back or to move away. Okay, so that was my escape escape mechanism. The defense mechanism may have been, I could have pushed something out to try to scare it or whatever. So then what happens is that it took a moment for me to recognize that it was basically a very simple, non-poisonous snake, and he was trying to get away faster than me. Okay. But the other thing that happened is, again, I had this diffuse emotional state. And so one of the things was that I'm immediately start looking around, because I'm starting to look around. If there's one snake, there may be another snake. And so I'm looking around specifically where I'm working at, because my concept is, well, this snake liked it here, which means other snakes would like it here. Or in one instance, the snake may be chasing another snake to eat, or tracking another one. My apprehension was not that I was afraid of this black snake, but my apprehension was that a few years ago, when I was working around my pond, I reached down and there was a copperhead. And the bottom line is, with the copperhead, is when I see snake, the next thing is there a copperhead around here? So that was this vague future threat. Is there another snake, and is it possibly there's possibly a copperhead there? I had a strong sympathetic nervous system arousal. I mean, my blood pressure, I'm sure, went up. I didn't measure it, but my heart rate, I know, sped up just a little bit. Other people may have other symptoms that are associated with this SNS, sympathetic nervous system stimulation. But again, my body, by seeing that snake, basically my body got prepared to address a concern, the fear. Now, there are irrigation pipes, and there is a garden hose that's black that's laying out. And there's times that I've been out, especially in the evening, early evening, where this dusk is about there, and walking, and I've seen, an irrigation, and I've had this response, as my mind immediately goes, is that a snake? So what this is doing is, this is not to freeze me or anything like that, but one of the things that we're doing here is basically it's preparing me that this could be a danger, and then my brain thinks through it and realizes it's not. Now, at that conference yesterday, there was an interesting thing, because there is they demonstrated, they asked how many people had vasovagal syncope, and that's where their vagus nerve basically fires too much, and these people faint. They've looked at animals, and for example, they showed a video of where a cheetah had grabbed an impala, and a hyena runs the cheetah off. The impala's laying there. We're seeing the picture. Looks like the hyena is basically, getting ready to rip this impala up. When the when the hyena went to run the cheetah off, basically the impala gets up and runs away. And she was saying that this happens sometimes in young deer or young impalas and things like that, and it's become a predation response. Like a young deer, if a wolf or something shows up, just faints. And how would that be adaptive? And she was saying, well, this is where, when the deer faints, they're not going to make the fawn faints. It's not going to be moving. It's not going to be making any noise. It's not going to send the normal cues out. So one of the things that people are starting to look at, which I thought was sort of interesting, is how that's adaptive. And we have to realize that, as we overcome some of these things, basically we are able to handle this. But again, our body is preparing us for that immediate effect there. So when you look at the basic neuroanatomy of this, what we see is we describe the fear pathway, and here you see that we have the amygdala becomes involved. You've got the cortex, especially with the visual. We're going to see something, and we got the thalamus. So basically, the way that it's described is, basically what happens is that your thalamus basically will send information to your amygdala. That sends out, basically blast out an alarm, as the slide says, to the brainstem, which is basically saying, hey, there's something up there. Get the autonomic nervous system kicked in. Let's get it going, okay? And what happens is that sort of strengthens the memory, so that next time we see something, what we find is that our brain sort of sets up with regard to this and prepares for it. So the other day I saw a snake, okay? A day or so later, I'm walking down the pathway behind it. I see a black, I see something black that looks like a snake. Well, my brain is already attenuated to seeing that may be a snake, so I'm on high alert. And so what we find is that reinforces this, and it helps us to learn the things to watch out for. And so this is sort of a adaptive response for us to keep us safe, if you will. So what happens now is, let's use my example. I'm walking down the path. I see a black tubular or snake-looking item. My brain, the danger is sensed, which means basically I see something that looks like a snake. All right. So what happens is my amygdala gets activated, which activates the sympathetic nervous system. Okay. When I get closer, or when I realize that basically that's just a piece of irrigation tubing, now what happens is basically my brain shuts off the sympathetic nervous system. Okay. But what happens is that with the snake that I saw, the amygdala gets gets programmed to remember the trigger. What is the trigger? In this case, a snake-looking like object, a round, elongated black object. Okay, so my hippocampus basically is going to remember that. And then next time, if I see a snake or I see something black that is, snaky looking, my brain gets ready, and then I can process it. But it is not. It is set up. If you think about it, it is designed so that it sets us up to be prepared for danger. And by doing that, it's helping us to be the most prepared for danger. versus if we had to wait and say, well, let me get completely up on it before my brain kicks in and goes, oh, that's a snake, and kicks back. That would be more of an issue, more of a problematic issue. Let's see. There we go. Okay. So the other thing is that when we look at anxiety, there's what we recognize as threats, and threats are really designed to, they're a function of interpretation. You know, the example I've been using, for example, I may see, I've got a worm, mistaking a worm for a snake because they look alike. But generally, you know, worms are much smaller than snakes. But if you put it, for example, a piece of hose or tubing or something like that, which could be indicative of a larger snake or something, then what we see is that basically if I mistake that tube for a snake, my alarm system really doesn't go up. I heighten my awareness, but the alarm doesn't sound. But on the other hand, if I make a mistake of thinking the snake, mistake a snake for a piece of tubing, let's say I reach down to pick it up and it moved, and people have done that, then I develop a lot of apprehension. So the misperception is a false alarm, but my physiological system does start kicking in. The physiological alarm is pretty real. So let's go over this slide and then we will take our first break. So if you look at, this is called the anatomy of fear. And basically, if you think about the autonomic nervous system, this is pretty much one of the things that you can see where all these different areas get kicked in. So let's go down here is basically, if you look, we're going to start where the pupils are here. So when we get activation of the autonomic nervous system, one of the things that happens is our pupils dilate. That helps us see. It helps us see better, helps us to perceive. Our ability to accommodate is going to be improved. So that is going to, especially when danger may occur sometimes in low light, the pupils dilating would help quite a bit. The saliva, we tend to get, our mouth gets dry. Body is basically saying we're going to move things to get you ready to either to fight or to run away. So the digestive tract in general is going to slow down. So you're not going to be digesting anything, your saliva. And actually some people argue by drying up a little bit in your mouth that may improve breathing. Your thyroid gland is going to release thyroid hormone to kick up your metabolic rate. Your lungs, these are all autonomic nervous responses. So this should be somewhat of a review. Your lungs are going to bronchodilate. That'll help you breathe better. Your hair stands up on end. Now, in humans, the argument is that what big difference does that make? In animals, such as a rat, the hair standing up actually makes the animal appear to be larger. But with humans, you know, the hair on our arms and legs is not going to make a big difference. Just going down this side, your liver is going to start breaking down glycogen, and that's going to give you energy so that your increased metabolic rate will accrue. Again, I'm just going to go around here. The adrenal medulla, you're going to get a release of epi and norepi, which is going to stimulate your sympathetic organs. One of the things is with bladder and colon, sometimes you will get where that they will void. There's a couple of arguments as to why this occurs, but one of the things is that to get rid of when people get scared, sometimes they have incontinence, and some people says it basically is to release the toxins and the things you're going to get rid of, so that if you get injured, that wouldn't help you. Some people say it's part of the defense response, that is a deterrent. For example, if a predator was coming after you. Basically, your GI tract, as far as your stomach and small intestine, blood is going to be shunted away from that. Basically, it's going to be shunted to the muscles. The spleen contracts, which pushes more blood into the circulation. Your skin, your blood vessels constrict. That's why people turn white. So from that perspective, that the blood is actually being shifted to the internal. Your heart's going to kick up, beat faster to try to and harder. But up in the brain, what we're going to see is basically um, we're going to see the amygdala is going to activate the autonomic nervous system, as we said. It's going to trigger the alarm system. It's also going to get you to remember what scares you. The pituitary gland, that's going to actually release hormones that will stimulate the adrenal and the thyroid gland. Your hypothalamus is going to take the signals from your organs, all of this information coming from your organs that's happening, and basically they're going to actually help shift blood where it needs to go. And then, of course, your hippocampus is going to help cement those memories there. So this is what happens, and again, it's the fight or flight response, but it comes into play with regard to people that have anxiety disorders. What we have is a maladaptive response to these anxiety disorders, and that's what creates some problems there. So it's important that you sort of know what's going on here. And again, when we talked about clinical medicine, one of the things that that I dealt with, we talked about was if you get activated with the autonomic system, what would happen to the different organs? So that should be just a review of what's happening there. Okay. And again, what I want you to do, let's go ahead and take our break. And I'm moving forward too quick. So if you would just sort of look over this slide and make sure you follow it, especially with some of the system, and it should fit in with regard to your autonomic system there. So let's see. I think again, let's go ahead and take our break. Let's come back. Let's see. Let's come back at 10 after the hour. And then we're going to pick up and talk about this fear response a little bit more. And Aiden, I'm going to mute here, and we'll come back at 10 after the hour. Would somebody, before you go, would somebody just type on the chat board, just put test, and let me make sure that that's coming through.
Hey, we've been chatting quite a bit. Have you not seen it?
No, that's what usually you guys are pretty good chatters, and that's why that I was sitting here thinking.
Yeah, we're chatting quite a bit. So
thank you that's what I got to figure out here, because for some reason it is showing the participants, but that's one of the things I want to do. Let me see if I can fix that.
Doctor, on the same panel that you choose the participant and share it, on the same panel on the right of the share, you can see the chat icon. And if you click on it, it's going to open up.
Okay, Aiden, well, I see the, there it is. Okay. All right. So guys, when you get back, I'm going to look through these and we will go around it. That's what it was. It was not showing this there. And so you guys I was thinking y'all are awful quiet here. So what we'll do is I'm going to look through these and we'll talk about it when we get back. So now that I've got that taken. All right. Thank you, sir. All right. So I'll see you guys at 10 after. You guys had been having a nice little chat going on there, so I apologize for getting there. But just looking back in it, those one mention was the fainting goats. When I was at Auburn, we had some pug dogs that would do that also, and those appear to be vasovagal, or one of the things that the animal people are talking about is that it's just an enhanced parasympathetic activity. What happens in most of those instances basically is that the vagus nerve seems to fire more prominently or to take over. And when it does, then basically what occurs is that the bottom line is that the heart rate slows down too much. So, but you know, some of the other things that you guys um, have identified there has been things that have occurred. One of the things that we see that does occur with a lot of patients that are worried about is, you know, the incontinence. And with the incontinence, sometimes can be anxiety in the autonomic nervous system, but also we see, especially in older patients, and sometimes in real younger patients, we can actually see a major concern with regard to some other issue that's coming into play. So, and sometimes that seems to be presented during, you know, where stress level is up, and that's one of the things that has to be identified here. I'm going to try to cut the mic up, but I think it is a delay that we're running into, and hopefully this will not continue on too much. Let's see. Okay. All right. So let's move on to the next slide. We're still talking about fear, and let's see if this. There we go. So one of the things that we find is that with the you know, if you think about it, that as I've said earlier this morning, is that normal fear and anxiety really is protection. Okay, think about it. If you did not have that anxiety or fear, one of the things that would happen would be, I mean, just like with pain is part of a protective mechanism, but the aspect of it is our process, our ability to recognize fear. I mean, you know, if you think about, like, for example, crossing a street, one of the things would be is that we get a little anxious sometimes when we are trying to run across a busy street. And one of the things that happens is that we recognize there's a danger there, but the fear of us getting hit by a car is sort of protective. It makes us be a little bit more vigilant. But what happens in these anxiety disorders is this normal fear and anxiety, which is typically protective and preservative for the body, is basically it becomes dysfunctional and distressful. And so the biggest aspect of how much does it actually create the dysfunction. And again, sometimes, and you'll see with some of these, we have medications to treat some of these anxiety disorders. Others we do not have with regard to that. So that is one of the things that we're wanting to do, is to recognize this and move forward. So let's talk about, let's start with some phobias, okay? This tends to, a lot of people joke about with regard to the to phobias and things like that. And so what we find is that when we grow up, as we're growing up, there are a lot of things that we're afraid of. I mean, people, if you think about it, people are afraid about, you know, altitudes. That's one of my fears. I'm not to the point where it bothers me to fly. No, in fact, fly never never bothers me. I do get nervous when I get up on a ladder that goes more than like 8 or 10 feet. And I keep telling people that it's not that I'm afraid of the altitude, the height. I'm more afraid of how I feel when I fall and hit the ground. So I'm not sure if it's really one of those things where that I'm afraid of heights, but you know, that's it. People are afraid of snakes. When I've worked with a lot of people to get them, it's my oldest daughter was deathly afraid of snakes. We have a picture of her when she was, probably in high school, and there's somebody who's put a boa constrictor around her neck, and she's just sitting there, just like almost paralyzed. Spiders. My wife handles a lot of different things, but the one thing that scares her to death that she does not like is roaches. And so if there's a little tiny cockroach that happens to come up, that is one thing. But over here in the South, we what we have here is these big, what they call palmetto bugs. And that is the one thing my wife, in fact, I had just had knee surgery, arthroscopic knee surgery, and had just gotten home from the thing, and there was one up in the bathroom, and she called and said, "You got to get up here right now." And so I went up the stairs and killed it. And then I had to actually crawl on top of the bathtub to kill it. And when I finished doing it, she looked down and she goes, "Oh, that's right. You just had surgery today." So I've been kidding her about that one for a long time. But, you know, the point is that I've gone through the rationalization with her, which is, you know, nobody has been killed by a cockroach, that they don't bite, they don't sting, and those type of things. But still, that is a fear that she has, you know. So one of the things, when it gets to be a phobia, basically what happens, that creates a lot of intense anxiety, and that anxiety is coupled with avoidant behavior. It makes sense. If I'm afraid of it, I'm not going to be around it. So the point becomes is that that can interfere with everyday living, to the point, like, for example, I mean, people used to kid my wife is because I actually many years ago collected snakes, and we actually had rattlesnakes in the house. That didn't bother her. I'm telling you guys this now, and y'all are going to go, okay, we don't need to be taking any more courses from him. But no, she, you know, she will catch a snake, and, you know, we release it and so forth. And I had rattlesnakes and stuff like that, and that didn't bother her. But a roach would scare her to death. So what you see is that when you worry about phobias is when they become the point where it interferes with everyday living. Like, for example, is you're scared of roaches, and, you know, what if it got to the point where that she's afraid of walking outside the house because of that? Well, you know, she couldn't go to work and do the things she wants to. So from that standpoint, there is a lot of different things that we have to focus on with regard to really how do we treat these, and do they need to be treated? That's a key point, is do they need to be treated? Now, sometimes individuals, it's like the cognitive therapy, just sitting down and counseling with them will manage it. And sometimes this is all we have. But the other thing is, you try to tell people is that, for example, we using snakes, for example, it's not that, this is the term we use, of this is that I'm one of these people that I'm not afraid of snakes, but I have a healthy respect for them. The poisonous snakes, I mean, I'm not going to reach down and grab a poisonous snake. I'm going to be able to handle them with a hook and things like that. But I'm also going to know that many times I'm just going to avoid those. So I need, you know, my body needs to have a fear of things like that. Okay. But what happens with phobias is we have an irrational reaction, where that basically it exceeds really the any realistic threat, is when it becomes a phobia. One of the things that we're starting to see is we're starting to see older people that are getting afraid to leave their house because of, you know, when they see the media about violence. You know, we had somebody a few 2 or 3 miles from here at a car wash from where I live. This little lady went to get her car washed, and while she's vacuuming it, basically somebody said, "Can I borrow $1?" and beat her up and stole her car. Well, we had a lot of older people that don't like to go out. We have a lot of older people don't like to go out at night because they're afraid of those type of things. So there is a definity. I mean, there's really a finite issue where that people need to recognize threats. When I'm taking Krav Maga, the issue is we learn to take a knife away from somebody, we learn to take a gun from somebody. But the first thing we tell people to do is, when we're training them, don't put yourself in those positions when you can. Be more vigilant. Don't look at your cell phone. Try to avoid those conditions. That is just being cautious. So let's go into just as a side on reptiles at this conference yesterday. I did not realize that we were talking about, one of the things they talked about was salmonella, and the salmonella outbreaks that occurs from people having pet turtles. I did not realize that the United States, these really small turtles you can't purchase if their shell is under 4 inches, but the United States exports them, and apparently Louisiana is one of the major states that exports. And over a period of time, the United States has exported 66 million turtles. I had no idea. And how does that fit with phobia? Is people sometimes are afraid of getting germs. So just as a little side trivia there, which just surprised me when I heard that there were 66 million turtles that were exported out of the United States. So here's a thing that you may be addressed with because, excuse me. Excuse me. So one of the things that happens with fear and stress and anxiety is that the patient may show up with another side effect that may present that is more troublesome. So we find that many times this is associated with the enhanced sympathetic activity. And so sometimes, for example, sexual dysfunction, we do find that females are less likely to ovulate or carry pregnancies to term. When under a lot of stress, we see erectile dysfunction in males. So sometimes when we see someone present, for example, a male presents with erectile dysfunction, one of the things we may want to look at is this stress induced? And maybe the best thing to deal with is trying to determine if there is some sort of stressful situation. We do see, for example, people that are trying to have babies sometimes stress themselves out so much to try to have the child that a lot of times, even though they're going through all the different things, one of the things that happens is they simply, we see this frequently happening, is they adopt a child and then the next thing you know, they get pregnant. And part of people blamed is because the individual, now that they've adopted, they have a child and they relax a little bit, and the sexual dysfunction is, or the stress that has created sexual dysfunction is abated somewhat. One of the things we find is people that get stressed, their mouth tends to be dry. That leads to tooth decay. The saliva has a very important function of washing the teeth, the bacteria and so forth away. So when your mouth gets really, really dry, you don't get that washing effect, and what happens is you get tooth decay. So a lot of people that get stressed, they talk about they get cotton mouth, that their mouth, gets really dry. It's difficult for them to talk, and that may be due to stress. Loss of appetite. A lot of people we see that they have increased corticotropin releasing factor, and they lose their appetite when they get stressed. But we also see there are stress eaters in people that basically channel their stress to where they're eating. One of the big things we see is altered GI function, diarrhea, constipation, nausea. Your chats that that was some of y'all mentioned with regard to some GI issues there. And this is thing, I had a good friend who was an organist at the very good organist at the church I went to, and I did not realize it, but she played the organ, and her husband was the choir director. And just out of conversation one time, I found out that she had to take, Imodium every time she went to play, because when she played, she was afraid of messing up, and that would create a lot of stress, and she would always have a scenario with potential diarrhea. And that stressed her even more, is what if I'm in the middle of a service and I have this episode of diarrhea. So again, with stress, we see a lot of things that sometimes may be episodic because the stress is episodic. But many times the patient may show up with regard to, loss of appetite, altered GI function, sexual dysfunction. Those are things that may be presented as an index of stress. On the other hand, when you're dealing with somebody with stress, one of the things is you may, in getting their, reviewing their systems and so forth, you may find that there are other symptomology that she is getting that basically is a good index or may be associated with stress. What we have to be careful about sometimes is individuals are possibly seeing their another physician that is prescribing drugs to manage these different properties or these different problems that are occurring. And so we have to be careful about drug interactions. And also, a lot of people, what they're doing is pretty much maybe self-medicating. That's another issue there. Rebecca, you ask about CRF. Is that when corticotrophin releasing factor increases, when your adrenal gland causes it to increase, that tends to suppress appetite. And I'll get you a reference with a little bit more detail for that. So I like this slide particularly because to me, I find this slide very easy to explain, use it to explain to sometimes students, but also with patients. And so when you look at anxiety disorders, what you see is that there is a persistent fear and anxiety that occurs too often, is too severe, and gets triggered too easily or lasts too long. So all of us develop anxiety. And as a result of that, we're going to have it, but many of us manage the anxiety without too much of a problem. Okay. But what we're worried about here is if it becomes persistent, occurs a lot. And what happens when I say too severe is basically it is causing us not to function optimally. And the other thing that happens is that it gets triggered too easily or lasts too long. So for example, if I'm afraid of cockroaches, the point is that I walk in a room and I look up on the wall and there's a little black spot, and I just freeze because I'm thinking there's a big cockroach. And then I realize what it is just like a knot hole in the paneling. And the other thing too is that it's not something, it's something that these people start dwelling about. It's like, well, I don't want to go outside because I think there may be a snake, or I don't want to, we see students miss class because they're getting stressed. Maybe they're becoming overwhelmed, or we see people that are missing work. And we see a lot of these type of things. And what happens is the least little thing that may suggest to them or be the trigger triggers it. So it doesn't take a lot. Anything that just, maybe they're afraid of confrontation, and that creates a lot of anxiety at work. Well, if somebody just simply asks them a question, they see that as a confrontational issue. And then what happens is once it starts, it's like your system gets going and it lasts for a long time. So it leaves them in a period of stress. And one of the big things we see a lot of times with these individuals is they get fatigued. They get absolutely fatigued. They're worrying so much about things that might possibly happen. And if they do happen, how they're going to feel and stuff, that literally the problem is that they're just tensed up all the time. The other thing that happens is sometimes when they go to bed, they're not sleeping, because what's happening is, bottom line is, they are, when they're not sleeping is because they're worried about tomorrow. They're worried about, like for example, my wife would go through a period is when we were in one apartment complex and we killed a couple of roaches in the house. Is like she stayed awake at night because she was afraid that there would be a roach that crawl across the ceiling and drop down on her. And so these are things that just disrupt a lot of aspects of their life. But I think this slide here is a good way. If you're trying to explain this to patients, this is one of the things, is to try to get them and say, we're going to, what we're going to do is we're going to try to put this back in balance. And my slide, there you go. I always have to check back to see if I went too far. Okay. So when we look at anxiety disorders, first of all, as far as symptoms go, realize a lot of the things that they feel are due to this activation of the autonomic nervous system, particularly the sympathetic nervous system. Okay. But the other thing that happens, and maybe you guys, when I go through this, maybe you guys can put some, a lot of you have different experiences with patients, and sometimes how those patients express things to you becomes very helpful to the rest of us from a standpoint of thinking about how we may want to explain it to anybody. But one of the things we see is with these anxiety disorders, we see people have overwhelming feelings of panic and fear. They are thinking the worst. They are thinking, um, we have people that think that the snakes come after them, or I kid my wife, she thinks roaches sometimes will stalk her. They have uncontrollable obsessive thoughts. Sometimes they have very intrusive memories of things that have occurred. This, especially with some of the things like PTSD, this can occur. But a lot of times individuals may think about things of what may have sort of started that root of there. A lot of times they can have nightmares, recurring nightmares of things that are happening. This nausea, sweating, muscle tension, that's one of the things that wears a lot and fatigues a lot of these individuals out. Is if you think about it, when you get stressed, here's what's going to occur. In fact, I want you guys to sort of do this if you can. But if you get stressed, we use the term tensed up. So one of the things with tensing up is your muscles contract. And a lot of times when people get stressed, a lot of times the muscles in the neck and along the back and shoulders will get very tense. You see people all the time when they're stressed that somebody will come up, they'll get somebody to rub their shoulders to sort of relieve. So what happens is when those muscles contract, first of all, if you were to take and try to just sit there at your desk while you're doing this and just try to just contract those muscles and hold them for a few seconds, you'll find out that it fatigues them, okay? The other thing that's going to happen is when those muscles contract, what's lying underneath those muscles? They're nerves. And those nerves, what happens is when you contract the muscles down on those nerves, that gets them inflamed and irritated. So a lot of times people, they get fatigued because the muscles are contracting or they're tensed up. I mean, think about this as just like you can even just take and tense up the muscles in your forearm and hold them for a few minutes and hold them for a few seconds and see, if you hold them for a few seconds, how long it takes before it starts to hurt. But the other thing too is that with this constant tension, you're getting fatigued because you're using a lot of energy. Another thing is those muscles are pushing down on nerves, which causes inflammation of the nerves, which can create a lot of different things. Okay? So there's a lot of physical reactions that occur because of the way your body is adapting to that tension. Just to give you an idea of how little it takes. I don't know has any of you ever had or known somebody that's had sciatica? Just out of curiosity. Okay. So several of you have. Okay, good. All right. I hope y'all haven't had it. So, but sciatica is the sciatic nerve runs down the back of your leg. And people that have sciatica, this can be extremely painful and bothersome. It can be painful, or sometimes what can happen is it can cause a numbing and tingling of your leg. Feels like sometimes you need to move your leg all the time. One of the things we discovered in males in particular is they carried a wallet. And simply putting a thick wallet in the back pocket and sitting on it, that was enough to push down on that nerve to cause pain and to cause tingling and inflammation. So it doesn't take a lot of pressure, and especially around your neck and shoulders. Those are two areas where that you've got a lot of nerves, and there's actually a lot of muscles there, and it's easy to push down on those nerves. So we do get a lot of physical reactions. People get sick when they're doing this. And then the other thing that happens is these stresses is their job. We run into things from where they're completely exhausted from tensions or from the stress and so forth, anxiety, where it affects their job performance. If it's the job that's doing it, they don't want to do it. They start missing days. They try to go home early. They call in sick a lot. Same thing, relationships. This can occur. So these are all very, very significant things that can affect someone's, life. Okay, so let's start talking about some specific, and let's start with panic disorder. Pretty common condition here. It's actually named after the Greek god of nature, which is Pan. And most of you are familiar with the panic disorder. What we do see is the lay public has a lot of misperceptions with regard to the panic, what a panic disorder is. A lot of times they talk about a panic attack when it may not necessarily be a true panic attack. But what we see that with panic disorder, we see it's a recurrent situation. So it's going to occur numerous times, and many times it's unexpected. Now, with the unexpected, sometimes or many times we may actually learn what is a trigger for these panic disorders. And so in one sense, it can be expected. We know if the person is exposed to this, that this is what will happen, but they may not expect to be exposed to it, I guess is it. Typically, these come on very quick. They don't last long, typically 5 to 10 minutes. Now, one of the things that you may see is with this 5 to 10 minutes is sometimes if it's severe enough that they may have some symptomology that lasts a little bit longer. But let's take a look at some of these symptoms because this is going to be important. Let me get my pen here. All right, so with the symptoms, one thing is shortness of breath, okay? They feel like they can't catch their breath. They're breathing real short and shallow. Those are things that happen. Palpitations, start feeling their heart beating in its chest. That is a big issue there. Chest pain, that is a concern there. Does anybody know what diaphoresis is? Just checking your memory here a little bit. Sweating, yeah. Some people sometimes call it a cold sweat, but it's excessive sweating. Sometimes it's a cold sweat because they sweat and the cooling aspect of the sweat makes it feel cool. They get chills, may nauseous, may start trembling. They may think they're going to die. They may lose control and become somewhat hysterical. Sometimes they just feel a numbness. They almost get paralyzed. And in some cases, they may actually have this feeling of detachment or, basically loss of reality. Does anybody have any other symptoms that you know of that patients have experienced and maybe they're the same, some of these same symptoms, but maybe the patient may call them something else? You might think of anything else. Okay. So one of the things is take a look at these symptoms. Tingling, dizziness. Okay, good ones. Good, yeah. Joy, that's a good one too. That sometimes this is an interesting one. Some can be extremely sensitive to touch, and this tingling can. And so if somebody reaches to touch them to try and say, "Are you okay?" or something like that, they can get that. The tunnel vision, that's another one too. Is that basically things they talk about that their vision just seems to focus in and they can't see peripherally. So those are some other things that the person may experience. But I want you to look at these symptoms. So number one is if someone suddenly experiences this, you're going to do a little bit of ruling out about what's going on here. But, think about it. You're in the elevator and somebody starts doing this. One concern is like shortness of breath. Are they having a heart attack? Palpitations, chest pain, symptoms of, okay? Even the diaphoresis and the chills, people do that. Nausea, these can very easily be mistaken for a heart attack. Shortness of breath sometimes can be mistaken for somebody having an asthma attack. Some people with them going crazy, that's another one there, is because they just become almost sometimes hysterical. Somebody may be thinking they're going into psychosis. Someone may think that they are maybe freaking out because they've overdosed with a drug. I mean, think about, some of these things. They're sympathetic nervous systems, and so stimulants, cocaine, methamphetamine. If someone has some characteristics of a meth addict, maybe, skinny person with a lot of acne and maybe looks a little sketchy, could very well think that they're, a meth addict or a crack addict having that major thing. One of the first things is, that most people, when they have these panic attacks, people that are observing it, and maybe even the first time the person has these, is they're afraid they're having a heart attack, which can kick their anxiety up even more, okay? So one of the things is going to be is that as we talk about this panic disorder, one of the things that's going to we're going to discuss is really what else, in diagnosing it, we have to rule out a couple of other things, which could be very serious. A person having a heart attack, one of the biggest things we worry about is someone that is having a heart attack and maybe they have a history of a panic disorder, and we just simply go, oh, they're just having a panic attack, don't worry about it. If you are ever in doubt, send them to the hospital, okay? Call 911. Shortness of breath, chest pain, and so forth, any doubt, safest thing to do is get them to the hospital. And then you can sort it out from there, okay? Now, sometimes this may be accompanied by other things, like sometimes this gets into sometimes with what Carmen, you mentioned there, is that the agoraphobia is sometimes they feel like that they are being trapped, they can't get away. That sort of that may or may not occur, especially some people that, depending on what is triggered it. But typically in diagnosing these, we're looking at one of the attacks has been followed by 1 month or more of persistent concern. So that's the other thing that occurs. People that have panic attacks, once they have had it, they become almost hypervigilant with regard to, they are worried about, what if I have another one? What if I had a panic attack when I went downtown? Let's say I was going downtown and was going to the bank and got on the elevator and had a panic attack. And I got through that, and everything like that. Now I'm back at home, and now it's like, what happens if this occurs again? So one of the things going to be is, what happens if it occurs again? And so one of the things that may happen is, I may quit going to the bank or getting in an elevator. Or I had a student that had panic attacks, and so his avoidance was to try to avoid taking tests, because anytime a quiz or anything came up like that, his first panic attack was actually not associated with the test. It just happened to be coincidental. But what he started doing was he wanted to have different tests and all these different things there. But there was a significant change in behavior to try to avoid the panic attack from occurring again. What is, just out of curiosity, those of you that have managed patients with panic disorder, what do you see as after that first panic attack, what is their general concerns? Fear of another, okay. Embarrassment. Now, with the embarrassment, one of the things is that embarrassment and shame, and that because we see this sometimes also with people that have epilepsy. One of the things that happens is if they have a seizure. We had a girl that had a seizure at our church, and she had a hard time coming back because she was extremely embarrassed with regard to that she had a seizure. A concern with especially older people of passing out, and where they may pass out. For example, what if I have this when I'm driving? Or what if I have this when I'm, by myself, or things like that. But a lot of times, one of the things with the panic disorder, there is a lot of people, not only are concerned about the, what if it happens again, but a lot of them are very, very embarrassed or ashamed of that, even though, because the other thing can happen is, I don't know, has any of your patients that have had this had any had any constant had any loss of bowel or bladder control? That's one of the things we see sometimes with people going into seizures, and the girl I was telling you about did not have this, but that's sometimes a big issue there. But that there's a sense of, what if this happens as no one's around? And so it's a big concern with a lot of these individuals, simply with regard to, what if it happens again? Is somebody going to be here to help me? Especially if they've soiled themselves, that can be a big issue, especially if it occurs in a public place. We do see some people that are, especially if they think they're having a heart attack, they think they're gonna die. But a lot of people would feel humiliated or embarrassed. Now, let's cover this slide, then we're going to take another break. We'll take our last break of this morning. So one of the first things when we're looking at these panic disorders, what we do recognize, as I said before, a lot of these symptoms are very similar to somebody having a heart attack, okay? Now, let me make a comment before we talk about the mitral valve. One of the things we used to say, or we used to think, was if somebody was an older person, 60, 70, or old, 60s or 70s, or a person in their late 50s that had a lot of cardiovascular disease, then we would almost assume there would be that was a heart attack. If it was a younger person, we usually didn't worry about it. But what we've discovered is there's instances where people in their 30s and 40s have had heart attacks. So we've sort of broadened our scope with regard to concerns. So that's one thing to be aware of it. But one of the things that we see, let's see, Joy, you had a statement here. That person, your patient had got a service dog, and putting on a tag that helped there. Yeah. Mm-hmm. So it is, and that's the other thing too, Joy, you bring up, is that cardiologists around here, not just around Athens, but everywhere, if you call a cardiologist's office and he's your cardiologist and you go, I'm having chest pains, shortness of breath, and so he's going to send you to the ER. He's going to tell you every time to go to the ER. He's not going to tell you to come in and see him. They're going to send you to the ER. And the cardiologist will tell you, we have sent many people that have indigestion, GERD, to the ER. Even if you said, I just finished eating a heavy meal, or I just had Thanksgiving dinner and I'm starting to feel these chest pains, and it's GERD, they're going to still send you to the ER, okay? But as you just said, Joy, one of the things is that, first of all, it can be very expensive when you keep going to the ER every time you have this. But, and Eddie, that's a good point, it's type 2 error. Too much to risk, because the cardiologist will tell you, if I'm wrong, then you've gone to the hospital, but you're still alive. If I'm right, you've gone to the hospital and you're alive. So the point becomes is it's hard to differentiate. Now, one of the things that may create some issues that we're interesting, there can be some positives and some other things, is I don't know if any of y'all have an Apple Watch, but the EKG, has anybody used the EKG on their Apple Watch? Or know of someone that's got an Apple Watch that's used the EKG? The Watch 4, I think, has it. The 5 is supposed to have it. It has got, and I have it on my watch, and basically, if you've never used it, is basically, there's a little EKG on app, and when you click the app, pretty much what you do is, when the app comes on, is you hold your index finger next on the crown, and you can actually see it. You do it for 30 seconds. I'm doing it while we're talking. And it actually will show an EKG there. Now, it's designed, and there's been some clinical studies that have suggested that it is pretty good for potentially picking up atrial fibrillation. But sometimes, like, for example, I've been exercising or something like that, it will not give me a real good EKG. I may have things like it looks like some extra beats or something like that, and it'll come in conclusive. So one of the concerns, it does say in there specifically, if you think you're having a heart attack, go to the hospital. And it even says if you're not feeling well, to go to the hospital. But we're getting improved abilities. And in fact, there's rumors that there's an app being worked on that will pick up blood sugar. And there was rumors that there's an app that Apple Watch is going to be able to, quote, smell different things or detect odors on your body. So maybe, if you're diabetic, that's going to come up. So we're seeing a lot more technology that's coming up that will, the good part of it is it can, like when I just did the EKG on my watch, it will save that, and I could show that EKG to my doctor. But what you also have to be careful about is your patients may try to self-diagnose, which may not be good. But one of the things that we do see is that panic disorder, you have to rule out mitral valve prolapse. So what happens with mitral valve prolapse, if you'll look at this, the mitral valve is over here. It's on the left side of the heart, and it's between the, it's right here. It's between the left atrium and the left ventricle. So what happens, if you look at the little inset here, the valve sort of doesn't close and seal. So what happens is that the blood seeps back up into the atria, and so the heart becomes very inefficient. And one of the things that you see is that a lot of the symptoms of mitral valve prolapse are very similar to the same symptoms we see with panic disorder. So as a result of that, basically what we're getting is a person with mitral valve prolapse may experience symptoms similar to a panic attack. So one of the things we have to do is rule out, is it mitral valve prolapse or is it panic? Well, what complicates things a little bit more is the fact that we see that patients that have panic disorder often have mitral valvulopathy, which means that they frequently will have mitral valve prolapse. So part of treating patients like that is to educate them. Well, sometimes we may go in and have to fix the valve, but sometimes it's educating them as to what to look for and things like that. So let's take our break. This will be our last morning break, and we'll come back at 10 after, and we'll finish up on panic disorder and go from there. So, all right. So I will see you guys at 10 after the hour.
Okay. Hi everyone. I'm also running the poll, so you can take it if you can see it now.
Cover a little bit more if I can get this little poll thing. There we go. So one of the big things is basically getting the individuals diagnosed correctly. But let's take a look at a couple of other things with panic disorder. Is that so we have prolapse, we have to work it out. But there's another condition that sometimes mimics the effects, and that's called paroxysmal atrial tachycardia. So what paroxysmal atrial tachycardia is basically, it's called paroxysmal because it occurs periodically, and it's atrial tachycardia, which means that the atria is speeding up, causing the heart rate to speed up. So what we find is that if the paroxysmal atrial tachycardia is occurring, basically what's going to happen is that the symptoms are very similar to what you see with panic disorder. Shortness of breath, the palpitations, maybe even the chest pains. These are all things that are the nausea, even the chills and the sweating can occur. What we do see is patients, about 2/3 of patients that have PAT. There's people that sometimes PAT, the only thing they show is they'll feel their heart maybe speed up a little bit. They'll feel their chest beat a little bit, and it'll go for a few minutes and usually stop. We don't necessarily have to treat those patients. At the bottom of this slide here, you can see where that so here's where you see over here. Let's see if I can, like that. See where this heart rate sort of speeds up and then it sort of slows back down. Sometimes many times this is bothersome, but they are a situation where that the person really doesn't have any. It really is. It's hard to treat sometimes because we really just treat it only when that there is somebody that is, for example, has a this is really disruptive. Sometimes we have people that think they're going to have a heart attack, and that really worries them a lot, and so we may treat it for that. But this is fairly easy to diagnose in the sense that how would we diagnose it? Yes, we run an EKG, but and Maribel, it is a medical condition, and so that would be something that that possibly their physician or cardiologist would treat. That would be not something you would treat, but it would be something that would be part of your rule out. But since it's occurring periodically, when they show up in your office, the situation may be that their heart rate's normal. So one of the things that one way could possibly be is that if they had one of these watches on, or there is a thing you can use with your iPhone called Cardio, which will do an EKG. So from those standpoints, you could have them do that, and then that would store it, and then that could be reviewed. But the other thing we might do is that we'll talk to their doctor, and their doctor may choose to put on a something like a Holter monitor. So that would be something where that they would put on that monitor and basically wear it, and we could see when it was occurring. So it may show up, if in your office, if you did a EKG, it may show up, but that would be one thing that we want to sort of rule out, because the patient is usually going to present with that shortness of breath and so forth. That is one of the very common things that we would see them showing up with. A more serious situation that could possibly occur is that partial seizures. This is, I think this is a much rarer situation, but sometimes a partial seizure can mimic some of the symptoms of the panic disorder. These may be some of the symptoms that you guys mentioned earlier, which would be sort of potentially a feeling like they're disconnected. We see things like, passing out, things like that. Some of those symptoms can occur with a partial seizure. So if we have a history that the person is, has seizures, that would be a concern that we might want to rule out. But generally what we find is the panic disorders, we probably see the mitral valve regurgitation as being one of the big issues, or one of the other comorbids or potential confounding factors, and the PAT. There's one other condition that may occur. Can anybody think of anything else that might sort of cause chest pains and those type of things that's pretty common? Pleurisy could potentially cause it. That wasn't what I was thinking about. Heartburn. So heartburn is, somebody with GERD could very well be showing some of those symptoms. And, what you might see with GERD is basically, was it occurring about the time of meals and what their eating conditions are and stuff like that. So those could be, that would be one of the things that, you could take a look at. By the way, did any of you see the thing that came out by the FDA that Zantac has some potentially carcinogenic impurities in it? That came out this last week from a standpoint of it's probably one of the manufacturer's issues there. A very similar thing occurred not too long ago with some of the angiotensin converting enzyme inhibitors. Yes, correct. So it wasn't too awful long ago was that the FDA issued a warning that the valsartan and some of the angiotensin converting enzyme inhibitors were contaminated. But somebody just came back out, I think Janet Woodcock, who was the former commissioner of the FDA, says, well, it wasn't as bad as they thought. So it's sort of been an interesting thing. It will be, I know there's some lawsuits that are being generated with regard to these nitrosamine, or these nitrosamine type compounds that may be contaminants there. My slides here or my slides are not advancing here, so you guys give me a moment here to see if it'll There we go. Okay. Yes. So Jason, that's ranitidine, and then it's over the counter, and that's what the FDA is warning about, is that the Zantac. It wouldn't surprise me if there was not some additional compounds along the same line um, that may be manufactured with these, and that shows back up too. So there. Okay. Now, let's talk about the biological mechanisms that's been associated with panic disorder. So what we find here is that because you're having the increased activity type thing, one of the first things that sort of popped out to people when they were trying to come up with with the mechanism was that we think of norepinephrine as being more the alerting transmitter. And if you look to the bottom right of the slide here, I've sort of given you like one of these little Venn diagrams. It shows norepinephrine basically is involved in, the attention, motivation, pleasure, and reward, dopamine with alertness and energy, serotonin with obsessions and compulsions, and then they sort of overlap with regard to, mood and anxiety and so forth. So one of the things that they found was that probably it's abnormal norepinephrine activity was the first thought, but they always say that there's always other transmitters can be implicated too. So one of the things that they found out is if you stimulated areas in the brain in monkeys where that there was a lot of norepinephrine, what they saw was Redmond actually demonstrated you actually produced panic attacks in monkeys. So that was one of the things that sort of kicked in. Excuse me, kicked in is, so we think it's norepinephrine. Other transmitters are probably involved, but if we stimulate these areas, we get panic attack. And we also saw that there's drugs that sometimes that affected norepinephrine levels could actually induce panic attacks in humans. So drugs that elevated norepinephrine in the brain would sometimes basically stimulate these panic attacks. So one of the thought processes came out was that maybe this was primarily norepinephrine that was actually producing these effects. And that was, again, notice what we've done is, one, we know that it's involved in these type of reactions. And if we we give drugs that elevate norepinephrine, we see that, or if we stimulate those areas, that was evidence that could occur. All right. There's always a concern with regard to, is there some sort of genetic link? And, the thing is that there were some studies that were done that said, yeah, there looks like there may be a genetic link there. They really were inconclusive. I don't know if there's been any additional studies more recently. What they did find is that there was, in people that had panic disorder, there seemed to be a duplication in chromosome 15 was one of the abnormalities they found. I'm not sure exactly what chromosome 15 was. But the two things that came into play from a therapeutic standpoint was they did see a polymorphism of COMT. And you guys remember what COMT, what's COMT involved in? Okay, I'll give you a hint. It's catechol O methyltransferase gene. So if you think about that there was a polymorphism of the COMT gene, this would suggest that there may be some abnormality or aberration there that would affect norepinephrine or other catecholamines. They also saw that there in some individuals there was an abnormality in the gene that programs for the serotonin transporter. So Maribel, when I was talking about the polymorphism of the COMT gene, so COMT is that's catechol O methyltransferase. So remember from your from many moons past that Abdullah, you got it there exactly. So what happens is COMT is you have MAO monoamine oxidase, no, MAO monoamine oxidase, and COMT. Monoamine oxidase and COMT are the two enzymes that break down catecholamines, norepinephrine and dopamine and epi. So if you have a polymorphism in that COMT gene, that may suggest that there may be some abnormality in the handling of these catecholamines. So it would be consistent with this panic disorder is if there was some abnormality there. People have tried to explain panic disorder. So one of the things people tried to say they've put forth was the cognitive behavioral model. So the idea here is that that your ability to sense anxiety is basically that there's you sense it, but it's a misunderstanding of your body in interpreting it. So that's what causes the sympathetic nervous system arousal. So what we do is that with this model, what it's saying is that, hey, you know, basically that I'm focused too much on my body sensations. And as a result of that, what happens is these cues that are associated with my normal anxiety, I'm more, they're more intense in somebody with panic disorder. And there's a suggestion that there may be a biological predisposition that occurs there. So what happens is that I've got an intense focus on my body sensations. So when I get sympathetic nervous system arousal, I interpret them literally illogically. Is basically I am interpreting them more out of a control or a dangerous situation than looking at them like I should be. So the sensations that I feel with sympathetic nervous system arousal is interpreted as I'm fixing to be harmed, and that's what initiates the panic attack. So one of the aspects of it is that basically it still involves sympathetic nervous system activity, but one of the ways is that basically when my sympathetic nervous system gets activated, and there's a lot of things that's going to activate my sympathetic nervous system, but what happens is when it gets activated, I am more I respond to it illogically or excessively. And so when my sympathetic nervous system gets activated, what happens is I go into panic attack mode. So that's one of the theories that has come out there too. The other theories, and we'll finish up with these theories here, and then Aiden, just to give you a heads up, is then you can give them the 3 tests and we can go from there, and then we'll break for lunch. But the other thing with the panic disorder is that people have come up with a lot of biochemical theories. One was lactate. The idea is that if you are chronically anxious, your exercise tolerance actually is decreased. And what people were saying is that one of the things that affects your exercise tolerance is lactate. So if you are people that are with panic disorder, is they have an abnormal lactate metabolism, okay? So one of the experiments they did to try to test out this hypothesis or this theory was what they would do is they'd give sodium lactate. Think about it, when you exercise, your muscles build up lactate. And so one of the things that slows you down or stops you is when you start feeling that burn, you get that buildup of lactate, and that slows you down. So one of the things they did is they took patients that had panic disorder, and they gave them IV administration of lactate. And what happened was that about somewhere between 50 to 70% of them actually developed panic attacks, whereas in the controls only 10% did. So there was many more of the patients that had panic disorder had panic attacks than the controls. And so that was the theory, that lactate was occurring. So the data really didn't support the hypothesis as they tried to get it. But what they did know, and what sort of progressed from this, was that they do know that lactate stimulates respiration, because when lactate builds up in your muscles, one of the ways that you try to offset that is to breathe more, get more oxygen in there, and it also changes the acid-base balance. So what they then suggested that how much hyperventilation occurred following lactate administration really determined what the panic attacks were, or whether they would occur. So that was sort of the theory that was put up there. Okay, that still didn't quite hold up, and but it did lead to what is known as the respiratory hypothesis, which is one of the ones that people are hanging their hat on a little bit more. What they're saying is panic attacks are due to abnormalities of respiration, okay? That what a patient that is prone to panic attacks, their body basically seems to be more sensitive from a behavioral standpoint to carbon dioxide. And also anything that results in an irregular respiratory rhythm that occurs after carbon dioxide. So when carbon dioxide starts to build up, basically our body is going to react to try to get rid of it. So what the the respiratory hypothesis is basically what it says is people with panic disorder, they have a low threshold for impending suffocation. So what happens is when carbon dioxide builds up, so what it's saying is literally that people with panic disorder have more sensitivity to carbon dioxide. So when carbon dioxide levels start going up in these patients, what happens is they have a low threshold, and so they sense impending suffocation. So that triggers a false suffocation alarm, which activates the autonomic nervous system. So this sort of arose out of the lactate hypothesis. There's still a lot of debate as to what really causes this. We do know that, we know there's the transmitters involved are probably norepinephrine and dopamine from that standpoint. But what actually perceives this, and one of the issues is that people have proposed the respiratory hypothesis. And basically that, again, like the cognitive theory is your body is listening. Your body is very sensitive to the signals of itself. And in this case, it's sensitive to carbon dioxide. So when your body, a person with panic disorder, feels like carbon dioxide is starting to build up, then immediately what they do is they basically kick into mode and they have the heightened autonomic response. So what happens is they get the shortness of breath. They start getting the palpitations. If you think about shortness of breath, we see that occurring if we see a buildup of carbon dioxide. We also see that our heart starts beating faster to try to perfuse tissues more. So it sort of fits with this, but again, there's still some debate with regard to, is this explain everything about a panic response? Okay. All right. I'm looking at whether I want to start. We're at a good break for lunch. Hey, Aiden, have you got the quiz up? First of all, let me ask you guys, have you got the 3 questions set up so you can give that quiz? Aiden?
Yes, doctor, it's on.
Okay. All right. So guys, go ahead and take the quiz. We will go over this when we come back from lunch. And then you guys, no, there's no pretest, Eddie. We've gotten rid of that again. And so we got rid of that. So we're just going to go this quiz. We will go over the answers to this quiz when we come back from lunch. We'll come back at 1 o'clock. And then if you would just look over the stuff that we've seen before, that we talked about this morning, and see if we need to go over or need to explain something. I'm going to get y'all. I'll get you a little bit more information on the CRF. So while we're at lunch, and I'll shoot that to you from there. But we'll start back on PTSD. We'll start with PTSD, and we will proceed from there. So go ahead and go to lunch, and have a nice lunch, and then we will pick back up starting at 1 o'clock. And I'm going to go ahead and sign out. And Aiden, if anything comes up, just give me a call. Otherwise, I'll sign back in a few minutes before 1. Okay.
Sure thing, doctor. I'll keep the poll on for another 10 minutes before I take it off.
All right. Sounds good. Thank you.